welcome back to our channel. In today's video, we will be learning about anxiety, how fear and stress are associated with anxiety, and the anxiety disorders. So without further ado, let's move on to understanding each and every disorder in detail. Now, everyone experiences anxiety at some point or the other. It's a sense of vague, unpleasant, excessive worry, which is associated with autonomic symptoms like headaches, palpitations, precipitation, mild stomach discomfort, restlessness, etc. Now, anxiety can be very normal in stressful situations like when you have to speak in front of a public or while taking a test. But it becomes a problem when this feeling of anxiety becomes excessive and hampers your day-to-day functioning. Anxiety disorders are associated with significant morbidity and are chronic and resistant to treatment. Now, these disorders include panic attacks, specific phobia, social anxiety disorder or phobia, and generalized anxiety disorder. Now, there is an exquisite interplay of genetic and experiential factors. The abnormal genes predisposes to pathological anxiety state. Anxiety can also be an outcome of traumatic life events as well as stressful situations or stress. Now, many of us get confused in the associations between fear and anxiety, whether they are similar or distinct. But even though the distinctions can be difficult to make, it is significantly different from each other. Now, let's understand how anxiety and fear are different from each other. Anxiety is more of an alerting signal which warns an individual of an upcoming threat or danger and enables a person to take the measures required to prevent themselves from the coming threat. Now, fear is similar to alerting signals, but fear is a response to a known, external and definitive threat, whereas anxiety on the other hand is a response to a threat that is unknown, vague and internal. Now, distinctions can be difficult to make because both fear and anxiety are caused by unconscious, repressed and internal object displaced to another object in the external reality. For example, a boy may be fearful of barking of a dog where he actually is afraid of his father or fearful of his father. So he associates this barking of the dog to his father. Now, according to the post-Freudian psychoanalytic formulations, the separation of fear and anxiety can be psychologically justifiable. For example, the emotions experienced or caused by a rapidly approaching car towards a person, whereas the emotions caused when a person has to meet new people can be extremely different in nature. The main psychological difference between the two emotional responses is the suddenness of fear and the subtlety and slowly progressiveness of anxiety. Now, anxiety can be conceptualized to a normal and adaptive response that has life-saving qualities on the face of the threat. For example, threats of bodily damage, pain, helplessness, possible punishment, separation from a loved one, etc. Anxiety prompts a person to take necessary steps required to protect themselves from the foreseen threat and act accordingly. Now, this preparation is accompanied by somatic and autonomic activity controlled by the interaction between the sympathetic and the parasympathetic nervous systems. For example, dodging a ball coming at your head, sneaking into a hostel room past your curfew time to prevent punishment, or running or catch a moving train. Therefore, anxiety actually prevents a lot of damage by alerting the person to carry out responses automatically to prevent themselves from the threat or danger. Now, people under a lot of stress may experience emotional and physical symptoms like irritability, anger, fatigue, digestive troubles, and troubles sleeping. The experience of anxiety has two components. The first is awareness of physiological symptoms like palpitations, precipitation, sweating, etc. and the awareness of being nervous or fearful or frightened. A feeling of shame may also increase anxiety. Now, motor and visceral effects of anxiety is known. Anxiety also affects your thinking, perception and learning. It also tends to produce a lot of confusion and distortions in the perception, which could be about time and place and the meaning of the events. These distortions can interfere with learning by significantly lowering concentration, reducing the ability to recall events or memory, and impairing the ability to relate one item to the another or one event to the another. That is, to make associations between people and events. So they are likely to select certain things in the environment and overlook the others in an effort to make certain and justify or prove that these behaviors or their perception of a situation that is frightening is justifiable. If they falsely justify their fear, the anxieties are intensified through selective responses and they find themselves in a vicious circle of feeling anxious, distorted perceptions and intensified anxiety. On the other hand, if they falsely reassure themselves by selective thinking, appropriate anxiety may be reduced and they may fail to take necessary precautions. Now let's take a look at the epidemiology of pathological anxiety. The anxiety disorders make up the most common groups of psychiatric disorders. The National Comorbidity Study has recorded that 1 of 4 people have met the diagnostic criteria for at least one of the anxiety disorders, and there is a 12-month prevalence rate of 17.7%. Women are more likely to have an anxiety disorder than men, and the prevalence of anxiety disorder decreases with higher socioeconomic status. Now let's discuss various schools of psychology and their theories about the causes of anxiety. The psychodynamic theory has explained anxiety as a conflict between it and ego. Aggressive, sexual and impulsive drives and urges or behaviors may be experienced as unacceptable, resulting in repression. Now these repressed drives may break through and produce automatic anxiety. Now, from a psychodynamic perspective, the role of therapy is not to eliminate all anxiety but to increase anxiety tolerance and to use it as a signal to understand and identify the conflicts associated that created the anxiety in the first place. Anxiety appears in response to various situations in the lifespan of a person. For example, a disturbing fantasy can be precipitated into an anxiety attack. It is often useful to relate anxiety to developmental issues according to the psychodynamic perspectives. Anxiety derives from the fear that the self may be fragmented or broken down into pieces because other people are not responding with the needed love and care or validation. It can also be connected to the perception of the self being invaded by an external force. Another source of anxiety could be a child who fears losing the love and approval of his parents. Freud's theory of castration anxiety can also be linked to Oedipal phase, where the boy believes that the powerful parental figure, which is the father, may damage the little boy's genitals or otherwise cause bodily harm to him. At the most mature level, the superego anxiety is related to the guilt feelings of not living up to the mark or internalized standards of moral behavior derived from the parents. According to the behavioral and learning theories of anxiety, it can be postulated that anxiety is a conditioned response to a specific environmental stimulus. For example, a girl raised by an abusive father may become extremely anxious on sight of her father, and through generalization, she may come to disgust all men. In the social learning model, the child may develop anxiety or anxious feelings by imitating the anxiety in the environment as in their parents. Now, according to the existentialists, people experience anxiety because of the feelings of living in a world which has no purpose at all. And anxiety is their response to that void created in their existence and the lack of meaning. Biological sciences have contributed in various ways. The first is autonomic nervous system. Stimulation of the autonomic nervous system causes several symptoms like cardiovascular, respiratory, gastrointestinal, and muscular. The three major neurotransmitters associated with anxiety include norepinephrine, serotonin, and GABA. The third contribution is brain imaging studies. The CT scans and MRIs occasionally show some increase in the size of cerebral ventricles. Genetic studies have produced solid evidences that at least some genetic component contributes to the development of anxiety disorders. Heredity has also been recognized as a predisposing factor to anxiety disorders. Almost half of all patients of panic disorders have at least one relative experiencing or affected by the same disorder. Now let's move on to the first disorder, that is panic disorder. It is an acute, intense attack of anxiety accompanied by feelings of impending doom. The anxiety is characterized by discrete periods of intense fear that can vary from several attacks in one day to only a few attacks during a year. The lifetime prevalence of panic disorder is in 1 to 4% range. Women are 2 to 3 times more affected than men. The only social factor contributing the development of panic disorder is a recent history of divorce or separation. Panic disorder most commonly develops in young adulthood. The mean age of presentation is 25 years, but both panic disorder and agoraphobia can develop at any age. Panic disorder has also been reported in adolescents and children. Of patients with panic disorder, 91% have at least one other psychiatric disorder. About 1/3 of people with panic disorder have major depressive disorder before onset, and about 2/3 first experience panic disorders before or after the onset of major depressive disorder. Other comorbid disorders are social phobia or social anxiety phobia, specific phobia, generalized anxiety disorder, post-traumatic stress disorder or PTSD, and other common comorbid conditions are hypochondriasis or illness anxiety disorder, personality disorders, and substance-related disorders. The biological factors include abnormalities in the structure of brain and its functioning, and dysfunctions in major neurotransmitters like norepinephrine, serotonin, and GABA. There are also panic-inducing substances called panicogens, which induces panic attacks in most patients with panic disorder. Structural brain imaging studies like CT scans or MRIs have implicated pathological involvement in the temporal lobes, particularly hippocampus and amygdala. Various studies have found that the first degree relative of patients with panic disorder have a 4 to 8-fold higher risk for panic disorder than first degree relative of any other psychiatric disorder. Psychoanalytic theories conceptualize panic attacks as arising from an unsuccessful defense against anxiety-provoking impulses. Now, many patients describe panic attacks as coming out of the blue, but according to the psychoanalytic theorists, there are clear psychological triggers for panic attacks. The onset of panic attacks are generally related to environmental and psychological factors. Patients with panic disorder have a higher instance of stressful events and they typically experience greater distress about life events than controlled subjects do. The hypothesis that stressful psychological events produce neurophysiological changes in panic disorder is supported by a study of female twin. Separation from mother in the early life, physical or sexual abuses in the childhood can also be accounted for panic disorders. The research indicates that the causes of panic attacks is likely because of the unconscious meanings associated to the stressful life events, and the pathogenesis of panic attacks may be related to neurophysiological factors triggered by psychological reactions. Now, a panic attack is a sudden period of intense fear or apprehension that may last from minutes to hours. It can occur in mental disorders other than the panic disorder, but especially in specific phobia, social phobia and PTSD. Unexpected panic attacks occur at any time and are not associated with any identifiable situational stimulus. But panic attacks need not be unexpected. Attacks in patients with social or specific phobias are usually expected or cured to a recognized or specific stimulus. There are also situationally predisposed panic attacks which may or may not occur when the patient is exposed to a specific trigger. They may occur either immediately after the exposure or after a considerable delay. The DSM-V diagnostic criteria for panic disorder includes recurrent unexpected panic attacks with abrupt surges that can occur from a calm state to an anxious state. For example, palpitations, precipitations, increased heart rate, feelings of discomfort, sweating, trembling or shaking, nausea or abdominal distress, dizziness, chills or heat sensations, fear of losing control or fear of dying, etc. The second criteria is that at least one of the attacks has been followed by at least 1 month or more, including persistent concern or worry about additional panic attacks and a significant maladaptive change in behavior related to the attacks. The third criteria is that these disturbances should not be attributed to the physiological effects of a substance or other medical condition. The fourth criteria is that these disturbances are not better explained or accounted by other medical conditions or disorders. Now let's talk about the clinical features of panic attacks. The first panic attack is completely spontaneous. Although panic attacks occasionally follow excitement, physical exertion, sexual activity, or moderate emotional trauma. It is important to recognize any habit or situation preceding these panic attacks. For example, use of caffeine, nicotine, alcohol or other substances, disturbances in sleep or eating, or other specific environmental settings. The attack often begins with a 10-minute period of rapidly increasing symptoms. The major mental symptoms include excessive fear or sense of impending death or doom. The physical signs include palpitations, sweating, etc. Patients often try to leave whatever situations they are in and seek for help. The attack generally lasts for 30 to 40 minutes and rarely for more than 1 hour. patients may experience depression during the attack and the symptoms disappear spontaneously or gradually. The major focus of the patient's attention may be on somatic concerns of death from a cardiac or respiratory problem. Depressive symptoms are often present in patients with panic disorder, and in some patients a depressive disorder coexists with panic disorder. These people are at a high risk of suicide. In addition to agoraphobia and other phobias, OCD can also coexist. The psychosocial consequences of panic disorder can also include marital discord, loss of time at work, financial difficulties relating to loss of work, and alcohol and other substance abuse. Panic disorder must be differentiated from a number of medical conditions that produce similar symptomatology. Panic attacks are associated with a lot of endocrinological disorders, episodic hypoglycemia, seizure disorders, neoplasms, etc. Sometimes it is also very difficult to distinguish between panic disorder and social phobia and specific phobia. Some patients who experience single panic attack in a social setting, for example an elevator, may go on to have a long-lasting avoidance of these settings, regardless of whether they actually have another panic attack there or not. Panic disorder usually has its onset in early adolescence or early adulthood. Although onset during childhood, early adolescence and midlife also occurs. After the first 1 or 2 panic attacks, the patients may be unconcerned about their conditions, but if several attacks follows, it becomes a major concern. Patients may attempt to keep these panic attacks secretive and hide it from their families and friends, which leads to them worrying more about the significant changes in the behavior. Although the patients do not talk about suicidal ideation, but they are at higher risk for committing suicide. Alcohol and other substance dependence or abuse occurs in about 20 to 40% of all patients, and OCD may also develop. The family interactions and performances at school or work can be severely affected. With treatment, most patients experience a dramatic change or improvement in the symptoms of panic disorder and agoraphobia. The two most effective treatments available are pharmacotherapy and cognitive behavioral therapy. Family and group therapy may help affected patients and their families to adjust to the patient's disorder and the psychosocial functions or difficulties that hinder or hamper on account of these disorders. Thanks for watching. In my next video, I will be taking up phobias and other anxiety related disorders like agoraphobia, specific phobia, social anxiety phobia or social phobia, and generalized anxiety disorder. So stay tuned, and if you like our videos, hit like and subscribe to our channel.